Welcome to Pathways in Pediatrics, the podcast of the European Academy of Pediatric Societies.
In this episode, we're looking back at the recent EAPS Congress in Lisbon.
Specifically, we're diving into one of the most packed sessions of the entire Congress, sleep and sleep disorders in children.
It was a fantastic session, a really practical, multidisciplinary panel giving clear guidance on some of the biggest challenges we face.
Absolutely. To start things off, Dr. Carmen Schroeder gave this brilliant 101 on sleep, and her first point was, I think, so fundamental. We have to stop thinking about sleep as just a nighttime thing. It's a 24-hour cycle, a circadian rhythm.
Exactly. You'd have to look at the whole picture, and that, includes naps. It's not just this period of rest. The functions are so profound.
Right. It's about brain clearance, like a nightly wash cycle for neuronal detritus. It's for memory, for brain maturation.
And mood regulation. That's a huge one. When those processes get disrupted, the consequences, well, they just spiral.
We saw that. The physical effects on growth, metabolism, even a higher risk of obesity, and then the cognitive hit.
Yeah, on attention, on learning. But there was one symptom that I think catches a lot of us out.
Oh, the hyperactivity.
The motor hyperactivity, yes. In younger kids, sleepiness doesn't always look like sleepiness. They fight it. They start moving a lot.
It completely reframes how you might see a restless child in the evening. And of course, the impact on the family's quality of life is just immense.
Which is a perfect place to start. Dr. Schroeder's first deep dive was on sleep in neurodevelopmental disorders, specifically ASD and ADHD.
And the numbers here are they're off the charts. We're not talking about a small comorbidity.
No, not at all. It's somewhere between 30 and 80% of kids across that spectrum. It's integral to the clinical picture.
With autism spectrum disorder, ASD, it's as high as 80%. That's 4 to 10 times higher than in neurotypical kids.
It's not just that they're tired. It actively makes the core symptoms worse. Anxiety, irritability, aggressive behaviors.
Even verbal and total IQ. So the Congress presenters used actigraphy data to show a very specific sleep profile for ASD.
Yeah, and two things really stood out. First, a big delay in getting to sleep. But the real signature feature,
The awakenings.
extremely long nocturnal awakenings. I mean, we're talking about a child being wide awake for 1, 2, even 3 hours in the middle of the night.
And they've identified a core reason for this, which is so important for treatment. Dr. Schroeder pointed to melatonin deficiency.
Right, and it's not just a little low. It's a production line problem. About 2/3 of children with ASD are producing less than half the melatonin they need.
So it's a physiological shortfall.
It is, and that leads to this incredibly actionable insight about the link between sleep and behavior.
The longest continuous sleep period.
Exactly. It correlates directly with irritability and stereotypic behavior. They found a 60-minute difference in uninterrupted sleep between kids with high versus low irritability.
Just 1 hour. That's a tangible goal.
A huge goal. If we can just add 60 minutes of solid sleep, we can directly improve those daytime behaviors that parents find so challenging.
Okay, let's shift to ADHD, attention deficit hyperactivity disorder. The sleep profile is quite different here.
Very different. And the symptom overlap is massive. Dr. Schroeder really stressed this. If you have a child with that classic triad in attention, hyperactivity, impulsivity, you have to ask about sleep.
Because poor sleep can mimic that whole picture.
Or at least make it a lot worse. The profile here is more about timing. Bedtime resistance, trouble falling asleep, and then real difficulty waking up in the morning.
But not so much the night awakenings you see in ASD.
Much less common, yes. The core issue in ADHD is often a sleep phase delay. Their internal clock is just running late.
So if we're thinking about treatment for both, what was the strategy?
The first step for everyone is a systematic assessment, a dedicated consultation just for sleep, using logs, questionnaires.
Then non-pharmacological first. Sleep hygiene, behavioral interventions.
Right, and she mentioned some great resources like the Manual from Autism Speaks, which is free.
But when you do need to use medication, melatonin is first line. But the type of melatonin is crucial.
Yes, and this links right back to the physiology. For ADHD, the timing issue, you use immediate release melatonin to shift their clock earlier.
Okay, to get them to sleep on time.
Exactly. But for ASD, it's a sustainability problem. They run out of melatonin overnight. So for them, you use prolonged release to help them stay asleep and bridge those long awakenings.
That's such a clear distinction. Okay, let's pivot. Professor Paul Gringras took us through pediatric hypersomnia and a condition with just a shocking diagnostic lag. Narcolepsy.
10 years on average, it's a tragedy. And the first hurdle is just identifying what he called true excessive daytime sleepiness, or EDS.
Differentiating it from just being tired.
Right. This is an irresistible urge to fall asleep. And in kids, it often looks like restlessness or irritability. In teens, it's a huge risk for accidents.
So what are the red flags we should be looking for?
Well, unpredictable naps during the day are just not normal after a certain age. The classic example he gave was a child who stopped napping at age 4, but then suddenly starts again at 6.
That's a huge clue.
A huge clue. And then there's cataplexy.
The muscle weakness with strong emotions, like laughter.
Yes. But in kids, it can be so subtle, not a full collapse. Maybe their legs just go like jelly for a second, or they suddenly seem wobbly or clumsy.
Which is why it gets misdiagnosed as a seizure or some other neurological issue.
Exactly. And that contributes directly to that 10-year lag. A decade of missed school, of being mislabeled. It's just devastating.
He also stressed asking about some of the more, well, bizarre sleep events.
The hypnagogic and hypnopompic hallucinations, these terrifying experiences of seeing or hearing things as you fall asleep or wake up.
Which can easily get mistaken for psychosis.
Of course. And another vital clue, dreaming during daytime naps. An older child shouldn't be jumping straight into REM sleep like that.
There are physical signs too, right?
Yes. About 3/4 of kids with narcolepsy have excessive weight gain, crossing at least 2 centiles. And precocious puberty is also common.
It's such a complex picture.
It is, which is why he mentioned some exciting new research on using a simple, dry EEG headband over a weekend just to screen for who needs that full specialist lab test.
That would be a game changer for cutting down that diagnosis lag.
A total game changer.
Okay, from a rare disorder to a common problem in a specific population. Dr. Jessica Tatard's update on obstructive sleep apnea, OSA, in children with Down syndrome.
And the prevalence here is, it's astronomical. Up to 83% of children with Down syndrome have OSA.
Wow.
It's a complex type of OSA driven by their anatomy, the low muscle tone, obesity. It's multifactorial.
The biggest challenge she highlighted was diagnosis. You can't just rely on symptoms.
You absolutely can't. This was the key statistic for me. 50% of kids with no parent-reported symptoms at all still had abnormal polysomnography.
So half of them are suffering in silence.
Which means we have to proactively screen this population. Polysomnography, the PSG, is the gold standard. But for wider screening, she showed that simple oximetry has real promise for catching the moderate to severe cases.
And what about treatment? Adenotonsillectomy is first line,
But it often doesn't work as well as we'd hope. Persistence and recurrence rates are really high, 50 to 70% persistence right after surgery.
which is why there's a growing role for drug-induced sleep endoscopy, or DISE.
Exactly. Because in Down syndrome, the obstruction isn't just the tonsils. It's often multi-level, the tongue base, other parts of the airway. DISE lets you see that whole picture.
But the most powerful data she presented was from the 2024 Necker study.
Oh, it was stunning. They screened and treated kids really early, from 6 to 36 months. And the group that got early treatment had significantly better neurocognitive outcomes.
How much better?
A 13-point difference on child development scales.
13 points. That is life-changing.
It's massive. And it underlines the urgency because over half the kids in that study had moderate to severe OSA at just 6 months old. We have to start screening in infancy.
Absolutely. Okay, our final stop is with Professor Oliviera Bruni and Pediatric Restless Leg Syndrome, RLS.
A condition that's about as common as sleep apnea, around 2–3%, but so often missed.
Because it's subjective. The diagnosis is based on those 4 core symptoms: the urge to move, worse at rest, better with movement, and worse in the evening.
Right, and the pathophysiology is fascinating. It's all about iron homeostasis in the brain and how that affects dopamine pathways.
So what are the clinical clues?
A strong family history is a big one. About 70% have an affected relative, usually the mother, and you have to listen to how kids describe it.
Ants in the legs.
Ants in the legs, electricity, crawling. And in toddlers, it might just be crying, where the only thing that soothes them is having their legs rubbed or moved. Parents might say they're like a horse in bed.
So it's a huge, unrecognized cause of insomnia.
A huge cause. And the treatment follows the pathophysiology.
Non-pharmacological first, of course. Sleep hygiene, massage. But then it's iron.
Iron is key. And this was the most actionable advice from that session. Professor Bruni said we should be treating patients with a ferritin level below 50.
Even if they aren't anemic.
Even if their general iron status looks okay, ferritin below 50 is the trigger. That's a real protocol change for many of us. We need to look specifically at ferritin for neurologic health.
And that's the proactive approach, isn't it? Ask about RLS when a child has insomnia. Ask the parents, especially the mother, if they have symptoms too.
You might diagnose two people in one go.
This whole session really drove home how sleep problems can be the engine behind so many other behavioral and cognitive issues we see every day.
It's so true. So to sum up, treating sleep can improve behavior in ASD. We need to be vigilant for those subtle red flags of narcolepsy.
Early screening for OSA and Down syndrome can give a 13-point cognitive gain.
And RLS is a treatable cause of insomnia, and it's often linked to an iron issue we can actually fix.
The unifying message from all the experts was really clear, wasn't it?
Crystal clear. Taking the time for a systematic assessment, a consultation dedicated only to sleep, is probably one of the highest impact investments we can make for a child and their family.
Which leaves us with a final thought for you to take into your next clinic. How many children presenting with what looks like ADHD or chronic fatigue or anxiety might actually have an underlying treatable sleep disorder that we could uncover just by asking the right questions?
Thank you so much for joining us for this review of the Lisbon Congress.
And we would love to invite you to continue this conversation with us in person at the next EAPS Congress. It's in Athens, Greece, from September 24th to 27th, 2026. Until then, we wish you well.